Welcome. My name is Cindy Prizio, the Executive Director of One Standard of Justice. We have a diverse group of people here tonight. We have two branches of government. I want to thank everyone, the legislators who are on the phone with us. We've got state's attorneys, public defenders, private attorneys, treatment providers, social workers, restorative justice practitioners, reentry professionals, justice involved or impacted advocates and their families, and our Connecticut citizens. And we've got people from all over the United States with us tonight. We are honored to share this space with you. All welcome. Our objective with the webinars is to provide information and education in a forum where it can be heard, as Senator Winfield has said. One Standard of Justice would like to open minds and hopes hearts will follow. OSJ is a Connecticut civil rights advocacy organization fighting to reduce sexual abuse and restore the constitutional rights and human dignity of over 6,000 people mandated to register and their families and friends. We believe first and foremost, any sexual offense is one too many. We also believe when there is sexual violence, the response should be to reduce harm, increase the restorative process, and provide healing to all people and communities impacted. We want to suggest that if you haven't seen our first webinar series, which also includes Senator Winfield as a co-sponsor and also a presenter, please go to onestandardofjustice.org. Our second webinar series on high-risk youth begins now, starting with leading expert David Prescott, who once hailed from Connecticut, then proceeds with prevention and wraps up with restorative justice for youth for all offenses, including sexual misconduct. OSJ began to identify the extent of collateral consequences of the war on sex or the war on sex crime. There's the receiver of the harm, the author of the harm, both sets of families, community, people who were falsely accused, others who identify as minor attracted, living law-abiding lives, the public defender I spoke to today who was traumatized by the adult court process, the treatment provider, and on and on. We are looking for common ground. However, let's not settle on trauma, but rather healing trauma. One Standard of Justice welcomes Senator Winfield, David Prescott, and Dr. Sharon Denniston, who is a juvenile advocate and public policy consultant recognized nationally. More recently, Sharon, as a member of the Association for the Treatment of Sexual Abusers, by the way, they're changing that name as we speak, Public Policy Committee, worked on ATSA recommendations for both juveniles and adults. Thank you to CTN for live streaming, and I will now turn over to Senator Winfield.
Good evening. My name is Gary Winfield, as was said, Senator in New Haven and West Haven. I just want to say that first, thank you to Cindy for being on the job and making sure that I am aware of these webinars that we've been doing and scheduling them so that I can participate. Glad to meet David Prescott and Dr. Denniston. Want to say briefly why I have participated in these and then allowed David to do his thing. I think lack of information in the policy space can be particularly dangerous. In Connecticut right now, we're having a conversation that's been going on for a few months about juveniles in a different sense than we're talking about tonight. But that conversation started off with all kinds of misinformation. Policy suggestions grew up immediately out of the lack of information, whether it was purposeful that we had the lack of information or misinformation or not. And that conversation shifted to a place where, whether people intended this or not, we were moving in a certain direction. We've seen this happen in many ways. You know, if you think about the crime bill that we had years ago, this wasn't just juveniles, but if you think about the crime bill that we had years ago, that's the same kind of thing. And when we think about people who have committed a sexual abuse, the same thing happens. We have myths about who these people are. We have stories that we tell, and those myths and stories become part of the genesis of the policy that we create. And from my way of operating, I want to know that we are dealing with the actual problems that we have. And that means I have to be about the business of breaking down myths. You know, whether we're talking about people on one side of the equation or not, you know, there's a myth about children who are abused who are asking for it. There's a myth about children who commit abuse were necessarily children who were abused. There's all kinds of information out there that may not be correct. And what we need to do is make sure that we know truly what it is that is happening, why these things happen, and the approaches that will make us safer. Look, in the world of politics, sometimes being involved in this conversation is not what you want to do, because this is a difficult conversation to have in those spaces. Sometimes in the world of politics, while we might think that this is the type of conversation we want to have because we would yield so much more for it, what's more important than getting the actual information in that world is the position that we've always had. Because it's easy to just stay in that position and defend it. And while it may be easy to do that, it's not safe to do that. It's not safe for those who we say we're protecting, or those who we don't talk about protecting but should be protected. And we should be about the business of making this a safer world. So I just want to thank Cindy again and One Standard of Justice for allowing me to be here. And I am very excited to hear what David has to say. Thank you.
Well, hey, all right. I see I'm the only one with the camera on, so why don't I get us rolling then? Thank you to everybody. And, you know, obviously this, the feeling is mutual on all fronts here. By the way, Senator Winfield, that is an awesome book collection that you have behind you. I saw a couple of titles that I need to look up. So, okay, time is short. I want to make the best use of it. It was nice to see some familiar faces. Hi, Bill. Haven't seen you in eons. And poor Tracy, who has heard me speak a bazillion times and probably knows all of my jokes. So anyway, welcome aboard, and lots of new names. And one thing that nobody knows about me is I actually grew up in Connecticut, not too far from where Cindy is. So as she was flashing the mailing address, I thought, you know, I think I know where that post office box is. All right, let's get into it. Adolescents who sexually abuse. What have we learned? Where have we gone wrong? I'm just going to cover a lot of ground in a short period of time and then turn it over to questions. Here's my email address, David Prescott, VT. That stands for Vermont, or very tired after about 7 p.m. Here on the East Coast, but davidprescottvt@gmail.com. And I also work with Safer Society here in Vermont, do a lot of private stuff. So a little of this, a little of that, busy all the time. So yeah, so what do we know and what have we learned? And I'm going to add some things to what's in the slides, but I just wanted to cover about 6 different principles. And the first is, when it comes to kids who've sexually abused, and nobody, I mean, abuse is abuse. I want to say that from the outset, that there's no excuse for abuse, and abuse poses an unacceptable risk of harm to those that experience it. However, one place we've really gotten it wrong is these are kids. They are not little adults. I've gone on record saying that more times than I can count. The one time I thought maybe I'll finally retire this part from the presentation, somebody sort of slapped their forehead or face palm and said, I never really thought of it like that. So I kept it in. These are kids, and we want to raise our kids in a way that they can someday raise kids of their own. So we have to be very careful about who we are and how we handle kids. The other thing that we've learned, the vast majority are not known to reoffend sexually. I'll bring some data in for those that are impressed and dazzled by data. Something else that we did not know 20, 30 years ago, or 35 when I first started doing this work. The current assessment measures help, but they're not the same thing as standalone instruments. That's important for a few reasons. That we need to attend to resilience and protective factors, the things that are going to help kids not get themselves into trouble in the future. And that we also need to assess the program. Not all treatments are alike, but you'll see what I mean in this. And we also need to assess the treatment provider. What I'm really saying here is the qualities of the professional influence outcomes. And I'll give you a hint. No kid ever came back and said, you know what really contributed to my success? You know what really made the difference for me was that awesome diagnosis, that psycho-nasty label that you hung on me. You know what else really helped was the time you were really harsh and confrontational up in my face. As we'll see, what our kids tell us years later after they're successful is it was the quality of the relationship that they had with the adults in their life. That's what makes the biggest difference. So just really briefly, adolescents are adolescents and not little adults. There's actually been quite a bit written about this. And that the more we've studied the developmental aspects of these kids, the more we're up against three different realities. The first is when a kid does get themselves into trouble, when a kid causes harm to somebody else, this is an opportunity to intervene. That's the most important thing. The other piece is that surprisingly, they have more in common with other kids who break the law than they do with adult so-called sex offenders. And this is for a lot of reasons. One of the things that we really got wrong back in the earliest days of the field was the belief that kids can have sexual disorders in the way that adults do. We forget that just as every aspect of teenagers is changing and developing over time, so is their sexuality. And that the kid that gets labeled as deviant on Monday very often actually has a different set of sexual interests and attractions by Thursday than kids change much more than we think. And if you just think about it for a second, the parents who are on this call will understand, like around the world and across time and place and culture, adults have had a hard time understanding the behavior of young people. So why would things be any different with kids who sexually abuse? Somehow we got the idea that once they were abusive, they would always be abusive. And perhaps that's somehow linked to the idea that if a person is interested in sex, that they will always be interested in acting on their sexual interests. And it turns out that it's just not that true. So moving on, most adolescents actually don't reoffend sexually. And the data here is just very, very compelling and frankly, very convincing. Let's start with this classic study, 2006, Lorraine Reitzel and Joyce Carbonell. I was happy to, I see that I'm sorry, the data is missing from this slide. A little bit of presenter error happening here, but that's okay. I have it memorized. What they found, they took 9 high quality studies, the best 9 studies that they could find. And they looked at what were the reoffense rates. And what they found was that kids who had completed treatment programs reoffended at a rate of around 7.37%. Now hold on to that number for a moment because it's about to get lower. What they found, so 7.37%, 7.37% of kids who complete treatment, and that compared to kids who didn't complete treatment or were kicked out of treatment or for whatever reason weren't able to complete it, reoffended closer to 20%, about 18.93%. So that alone taught us, wow, it looks as though our effortful interventions, our attempts to engage kids in treatment actually is producing a significant effect. So kids who go through treatment do better than kids who don't. So one of the take-home messages from this is we need to provide treatment in a way that our kids can stick around, where they're liable to stick around and actually complete treatment. Now that's 2006, that's 15 years ago. This guy, Michael Caldwell, came along 10 years later and said, What about all the studies that have been taking place since the turn of the century, meaning the year 2000? And this is where things get really interesting. So he took all of these things now. He knew something that the rest of us had forgotten, which was during the latter part of the 20th century, there actually was a significant decrease in the amount of crime by adults and by kids. Some of you might remember this. Now, what was grabbing the headlines back in those days is, oh, watch out, all these kids that are born addicted to cocaine, they're going to become super predators. This really was a theory at the time. Some of you will remember. And they talked about the rising tide of super predators, only it turned out not only to be wrong, but wrong in the completely opposite direction. So Caldwell is looking at this, and what he did was he studied all the studies done since 2000, and he came up with a reoffense rate of 2.75%. 2.75%. And this is really remarkable. And who knew, how could this possibly be? Now, I, like many others, emailed Mike and said, that's lower than even I think. And I agree from my own practice, this is really low. What about like severely mentally ill kids or other kinds of kids that might be predisposed to do it again? And he said, there weren't a lot of studies to begin with. They weren't particularly high quality, but even if I had included those studies in my meta-analysis, it wouldn't have changed the outcomes very much. This led to a lot of us saying, this is really something. Now, Mike's take on all of this and what he's said publicly is, actually, this is because people are talking about the issues and people are willing to do something about the issues. The real moral to this story here is, nice work, everybody. However, we still have a long way to go because of all of the things that Cindy has referred to already that we've put into place that cost us money, but have been shown not to be effective. Things like registration and notification and so on and so forth, the research has actually been quite clear. They might have seemed like a good idea at the time. Then again, so did DARE and so did Scared Straight, both of which were shown scientifically not to work. As in scientifically not to work, as in everybody thought it was a great idea. It didn't work. And it's time we get over that. Even if you don't trust scientists or science, this is what the data has shown again and again, especially when you look at big numbers of people who've gotten themselves into trouble, caused harm to others. Many questions, of course, but that's for another day. Here's the rest of the slide. So obviously, like I said, presenter error. Yeah, this is it. The follow-up period averaged 4 and 5 years. There's the numbers: 7.37, 18.93%. Sorry, I think I said 18.91. You get the idea. What are the implications? Treatment works. Treatment certainly can work, and when it does seem that when it's combined with some other degree of supervision, like by parents, it works even better. And the right treatment approaches with the right client can have a really, truly positive impact. Again, this is the data, and nobody's ever produced any data to suggest otherwise. It would take a lot of evidence to make this untrue. So therefore, our job as professionals is to create willing partners in change. Okay. So I'm going to sort of rush through this part because it might not apply to most people on the call, but it is interesting to me that we don't have any kind of like magic bullet way of telling who is going to reoffend and who isn't. So this woman probably did the best work in this area. Her name is Jody Villuin. And what she did is she went and took all of our risk assessment scales and mixed them all together and found basically that they all ranged as in the range of effectiveness was basically in the moderately predictive range. In other words, better than flipping a coin, but very, very far from being perfect. So what this has led me to try to remind folks is that we do a really bad job, even with a good algorithm, with a good psychological test, with all of these things, we have a really hard time figuring out which kids are going to go on and do things again. They also found, by the way, you see moderate to high variability across studies. What this really means was professionals really doing their job with diligence actually did a pretty good job of figuring out who was more dangerous than others did. And they did a lot better than when it's somebody trying to do a study to meet the criteria of their graduate school studies or whatnot. So all of this leads to some cautious optimism, but we are very, very far from perfect. Okay. Resiliency and protective factors. We just haven't thought about these. The age-old question in the old days was, what's his level of risk? How dangerous is he? And we always had this kind of mindset of, but don't they all do it again? And even if they're not known to do it again, isn't it because of their deviance that's lurking somewhere in the background, and that they're just waiting for the right time to do it again? And people tried to study it, and they couldn't find it. One of the great failings in our field is the idea that that these kids were as sexually deviant as their adult counterparts. We tried everything from studies using the penile plethysmograph, which frankly and bluntly measures penises in response to erotic and semi-erotic stimuli. And what they found was that the kids just changed. What was arousing to them one day wasn't so arousing to them the next day. And we forget this. And so our field got very, very caught up in figuring out what are the risk factors without also asking what are the resiliency factors and the protective factors. Bottom line, folks, is after 38 years in the field, I think I've been doing this, I've come to the conclusion that if you want to look for risk, that really what we need to focus on is the fact that these kids are at high risk not to live up to their full potential as human beings. And that if we're really serious about raising kids, maybe we ought to focus on how do we build their strengths? How do we build all of those little factors in their lives that are going to protect them from doing this again? I'll give you a hint. In my view, it's all about engaging the families to the best of our abilities. So there's been all kinds of protective factors. This is drawing from the work of a couple of old friends of mine from long ago, Janice Bremer and Jane Gilligan. And they were finding things like you see here, supportive families, education, and stability in one's daily life. And I see the comment here, thank you to Tony. Supportive families, education, stability in one's daily life, adequate knowledge about human sexuality, having a confidant, someone that they can speak to and trust, an ability to regulate their emotions, opportunities to explore one's interests, and it can be as simple as hope, having hope. We should be hope merchants with kids, not registrants and what have you. This turns out to be really, really important. Oh yes, and having plans for the future. How could I forget that? The most stable person in the world is the person that's, the safest person in the world is the person who's behaviorally stable, is occupied with a job or education, who has people to whom they can be accountable and to talk, has plans for the future, and therefore everything to lose by doing it again. More recently, Jim Whirling, a friend, colleague, as well as a hero, has also been looking at protective factors and reminds us of these things. Hope regarding a healthy sexual future, respectful sexual environment, balanced interests, a person who's compassionate and caring, has good self-regulation, all of these kinds of things. And another comment coming in, hope is everything to a child. Absolutely, absolutely. And I don't know how we missed this when we were out looking for risks. So just one of the most important things for me that we've really learned is how important it is to involve families. Now, what you see here, Prescott in-house fit data, this has to do with session by session feedback, that's the F, and how it can inform treatment, that's the I and the T, feedback informed treatment. And I oversaw programs in Northern New England where we were collecting feedback from our kids on a session by session basis and realized what we were missing was even when we think we're involving the family, our kids need their families more than ever, especially when they're in treatment. As my grandmother once said to my mother, you're never done being a mother. And I think the flip side of that is you're never really done needing your parents. And those of us that have lost our parents, I think can probably relate to this. Anyway, there's all kinds of ways to do this. And, multi-systemic therapy, functional family therapy, these are models and methods and techniques. But the bottom line is the best value for the effort is often in working with the families and treating the families. Okay, the right-centered, person-centered treatment makes a difference. This, oh yes, just a quick case example from my own practice. I've called him Chris, but Chris came into one of our programs. He had serious sexual behavior problems, and he also had a serious speech issue. And anyway, long story short, the clinical director at the time, this was a long time ago, said, David, don't put this guy into treatment with you. Would you just get him a referral for speech therapy before we do anything? And what happened was something really interesting. We got him into speech. He was able to work through some of his speech issues. And the next thing you know, he was experiencing interpersonal competence. And long story short, it was a domino effect. By giving this kid the ability to speak clearly, all of the other things that were going on in his life kind of took care of themselves. And he became much more interpersonally competent. And that was the biggest risk factor that he had, was this sort of social isolation from others. So we discovered that we actually were able to save a lot of time in treatment simply by getting him a speech therapist. And the complicated term for this is cognitive transformation. It's that moment in your life when you realize you're not who everybody thinks you are. Cognitive transformation is when you say, I guess I had to go through all of that stuff in my life to become the person that I can be, the person that I maybe am today or will be tomorrow. When we start thinking about how do we get people to change and not merely reduce their risk, we can go a long way. And so the last of my things is the quality of the professional can significantly change outcomes. And this is where I come in with the work of Bill Marshall. And here's Bill. He's now since retired. But he did a number of studies finding that professionals who were warm, empathic, and rewarding and directive were actually producing the best treatment outcomes. We used to think harsh and confrontational. Well, I didn't, but many people did. I think flowing out of the sort of hot seat therapy for substance abuse treatment way back in the 1970s, when it was thought you had to be confrontational. No, the true meaning of confrontation is actually, do we get our clients to look in the mirror and become confrontational towards themselves? Could I do a redo on that? Confrontation is a goal. It's not the method. Confrontation is when you look in the mirror and you say, am I really the best I can be? That's what treatment should look like. That's what treatment should look like. The problem is many professionals think that they have these qualities, but they don't necessarily. Have you ever met anybody that says, I really need to be a more empathic human being? I mean, I have, but they've said that only after a lot of in-depth conversation. In 1979, Edward Borden came along and he started talking about the therapeutic alliance. It's when you have the right relationship and you're working on the right goals and the right tasks and treatment. This guy, John Norcross, came along in 2002 and added strong client preferences, like I can only work with a male therapist or what have you. When they really feel strongly about it, that also means something in terms of this idea of building the best alliance. And I mention it because over 1,100 studies have since emphasized the importance of the alliance in psychotherapy. If you want evidence-based, focus on the alliance. It's the most evidence-based thing that we've got. Okay. So this has led me to the age-old question, how is it that people actually do change? And I think about our treatment programs over the years and I ask, did people change because they challenged their distorted cognitions, as we like to call them in treatment sometimes? Somehow that's not making it. For me, did people change because of the awesome homework assignments that we give people? Again, I think homework has its place, but it's just not the real the real thing, not at the center of it all. And I'm seeing the message here about high risk youth. Yeah, I'm getting there. Do people change because they follow the manual? Or do people change because they have a new experience of themselves and a new discovery? That, for me, is where change really happens. That sometimes our kids have a relationship experience where hope and possibility are renewed, or born perhaps for the first time. So I always say, when we come in with our empathic and attuned interventions, they'll always be unexpected, they'll always be welcome, and they will always be they will always be impactful. And that we have to have the things that you see here: the right mindset, heart set, spirit, attitude, and intention, and above all, compassion for the kids that we're working with, which flies in the face of a lot of our more unfortunate public policies. Too often, our political climate looks something like this: coercion, shame, blame, threats, and punishment. And at the end of the day, I believe really we can leave nobody behind. Listen, I know time is tight. I want to get to a couple of points. I've already gotten an important question, which is, so what is a high-risk youth? Who are the high-risk youth? And I've been stewing over this question for days now. And, we got to think in terms of youth and adolescents. And I'm really thinking here with adolescents, anybody from the age of about 12 on up to the age of 18, although if we're honest, many kids take longer to grow up, by a cow country mile. So what's a high-risk youth? I've come to the conclusion, I'm not sure I've ever met a truly high-risk youth. And I've had kids go on to do it again, but the ones that I've had that went on to do it again actually had been assessed as being at low risk and ended up in high-risk circumstances. When I think about what is a high-risk youth, I think of the kid that has, for whom adults have not been able to reach him, or the kid who is living under highly adverse circumstances, or the kid who doesn't have any supportive adults in his corner. I also think about the amount of trauma in the kid's past that's gone unaddressed, and he or she ends up not having any place to go with it. Again, time is tight, so I'm trying to come straight to the point here. What I'm really coming up with is, when I think of high-risk youth, I can't identify any, but I can identify high-risk circumstances, those various things that get in the way of a kid's ability to live up to his full potential. What have we missed along the way? While we were thinking about things like deviance, we missed that sometimes the thing that gets kids into the most amount of trouble is good old-fashioned impulsivity, impulse control. And what else have we missed? We've missed helping boys become men. Now, as you can see, I come from, I'm the obviously cisgendered, pretty well privileged, middle-aged, or nearing the end of his career, white guy on this call. I keep coming back to, what kind of man does this kid want to be? Or what kind of Black man does this kid want to be? Or what kind of Latino man does this kid want to be? And we miss this. So I'm seeing the shame, blame, and lack of compassion are not only the basis of our laws and policies, but also prevalent in too many treatment programs. Yeah, I happen to agree. What can be done to promote compassion-based treatment for children who offend as well as adults? Well, my answer to that is we need more folks like Senator Winfield and Cindy Prisio, who are not just paying lip service to it, but willing to promote this kind of an approach. And I think we need to get out there more with the research. I think many programs need to hire consultants. It's very, very easy for programs in a race to the bottom financially to say that they're doing things, to pay lip service to things when they actually aren't. The programs that are out there that are desperately trying to cut costs at the same time as they're touting the work that they do with kids. This is a pretty tough situation. I'm sorry, I'm just being honest. in my answer. So what is a high-risk kid? A high-risk kid is the one who is failed by the adults after he's managed to hurt somebody or get himself into trouble or what have you. So I see 18 minutes to the hour. So actually that might be a good time to turn it over to Sharon for additional discussion. Oh, the last little data point that I didn't get to cover earlier is, did you know that a third of sexual assaults in one study by David Finkelhor's group, 1/3 of all sexual assaults were perpetrated or committed by kids? So this is a major issue. As take-home points up to this point are, there's a lot of abuse out there. And the vast majority of people who do have adults telling them not to do this again do not go on to reoffend. And that, just as Carl Hansen in an earlier webinar for this group probably talked about the fact that if you can keep people safe in the community for 5 years, their risk goes down by 50%. That number seems to be the same for kids as well. Our real task is to help kids become adults. So I think I covered everything. Sharon, anything else that we should talk about? Any other questions that are coming in? It was a great question that I saw here.
Yes. Many times when people think about treatment for juveniles, especially when there's a sexual offense, they think sex offender treatment. And not always is a juvenile in need of sex offender treatment. So could you talk a little bit about that?
Yeah. So there's a few ways to look at it. Number one is, these kids statistically are almost always at higher risk for something else. They're at higher risk for violent, sort of non-sexual violence. They're at higher risk for getting themselves into other kinds of trouble with the law. I'm just watching as comments come in. And as I said, they're at risk not to have the life that all kids should have the opportunity to build. So yeah, a kid causes some degree of sexual harm. My guess is safety first, safety first, safety first. There should be some kind of effortful intervention. Does it have to be offense specific? Absolutely not. Out in the state of Utah right now, I hope I'm not telling tales out of school, but in the state of Utah, they've actually come up with this massive flow chart for everything you should look at to decide, does this kid need like deep dish treatment, or does he need something else? In other states, they're developing screening tools to say, wait a minute, does he need treatment? And if so, what kind of treatment? A lot of kids that I see need this much abuse-specific treatment, knowledge about laws, consent, what it all means, and to some degree, some opportunity to challenge the beliefs that they've held about sex and sexuality for a long time. They need this much of that, and they need a lot more about coming to terms with issues from their family of origin, trying to figure out what they're going to do with their life, how they can become the man or woman that they want to be, et cetera, et cetera, et cetera. So they actually need this much of that, but only a limited amount of the sex-specific stuff. Did that answer your question, Sharon?
Yes.
Yeah, thanks.
I found that many people assume that they need this much. I can't see my whole picture because my screen because I'm looking, but they need this much on sex offender specific treatment. And that's the impression I've got along the way, that's not the case.
Yeah, and usually what I always point out is, yes, of course we want evidence-based treatment and all of that stuff, but what we really need to is assessment-driven treatment. So then I hear people come along and say, yeah, well, these assessments are so expensive. And I know there's actually a clinical director out in the Midwest who said he's fielded complaints. Are you kidding? $300 is way too much to pay for a psychosexual assessment. I'm like, are you kidding? When you consider how much it costs to fix your car, or in my case, my dishwasher, but that's a much more depressing story. It seems like a very great bargain. Our kids need an assessment by a trained professional who can figure out what actually needs to happen. The problem is so many of us work in silos. The people who just work with kids are over here and freak out at the least mention about sex. And then there's the people who can do a good sexual behavior assessment, who very often are overworked and underpaid and overbooked, but who could be properly, easily feeding these kids over to the, that's not a good choice of words, you know what I mean? It's how I talk to professionals who could actually be referring these kids over to these treatment providers, but who are afraid about the liability and risks involved in treating a kid who's done something problematic sexually. And that's where we need to do a lot of work at the front lines in the community to make sure that people like judges or child protective services or others don't overreact just because of sexual misconduct. That's where a good assessment can really come in. I see a comment. We believe treatment over incarceration for all Connecticut youth. And I certainly agree with that. By the way, your colleagues in the state of Maine, I think there was a vote recently to shut down the last juvenile detention center, which did kind of have a supermax feel about it. Here in Vermont, they also did the same thing. And we only had a tiny little juvenile detention center, but it got shut down. And those kids are now being treated in sort of disparate residential facilities to try to build in as home-like an atmosphere as possible. I know in other states, there's been discussion about it. I just thought I would work that piece in.
Here's I'm sure there could be a whole webinar on this, but it's a very important question because it really supports primary prevention. The question is, are there signs parents will see in their children that allows them, that gives them the ability that shows they have the ability to sexually abuse other children? So they're looking for signs that parents might see that might alert them that they could be a child that might abuse other children.
Yeah, so I'll answer this with an extreme note of caution that you haven't been a parent until you've said to yourself, my 13-year-old is really freaking me out right now. So we need to start there, and that kids can present with a lot of really, really weird behaviors. There used to be a guy named William Friedrich, and he did some research on the sexual behaviors of children. Now, when I say sexual, I don't mean like adult sexuality, but rather what kinds of things are actually considered to be developmentally normative. The things that I would be looking out for is, does your kid have a combination of a high level of sexual interest? Has he been making statements to the effect that he sees sexual abuse or sexual violence as a viable behavioral option? Does the kid have an adequate fund of sexual knowledge? Sorry, translate into English. Does he have a good amount of sexual education in his background? Does he have a high level of impulsivity? Is there a high level of anger or a sense of grievance, as in everybody else has it easier than me? I'd be looking out for those kinds of things as, do we see various clouds, storm clouds gathering on the horizon that might come together and turn into a real storm? When I hear those kinds of things, particularly the attitudes that tell me this kid is porn educated and is viewing or has been exposed prematurely to sexuality and is then thinking that this is a viable option in his life, those are the places where I would want to intervene early and remind that kid, for example, that the stuff you see in pornography really, actually, most times isn't sex. It's a distant cousin to sex. And that most of potential sex partners don't want anything to do with sex as it's portrayed there, et cetera. I don't know if that helps any, but you're right. It could be a webinar for all day.
Mm-hmm. Yeah, I can't remember her last name, but Christina, the woman out of Canada, who's spoken at ATSA several times, is
Yeah.
very good on speaking about the developmental, normative developmental sexual behavior.
I'm blanking on her name too. If
I
you were
know,
to,
I'm trying to think of her last name.
yeah, the name, if you Google search the name Russ Pratt, Pratt, along with what he calls savvy consumer model. He has a savvy consumer model. I mean, we're never going to get kids to stop looking at porn. It's out there. If you don't believe me, look at the research, Debbie Herbenek, but also just go and visit any middle school and you'll see what I mean. But rather, how do we teach people to be savvy consumers of what they're exposed to? Oh, the other piece, how could I forget this? The other piece in that mix would be, alongside those attitudes and beliefs, would be early onset of alcohol use. Because one thing that we forget is that alcohol and the wrong attitudes can be a really, really dangerous mix. And frankly, the difference between some people who are on the registry and some people who aren't can be as simple as a six-pack and a really bad decision. It's the unfortunate reality.
Isn't that true of a lot of juvenile behavior? Six-pack leads to a lot of things. Joyriding, all sorts of things.
Oh,
you know,
yeah. And
drug use.
Yeah, we saw what happened in American history with prohibition and all of these kinds of things. But I think education, discussion. And a lot of my messaging to parents is this stuff is closer to you than you think. And there's a lot of dangerous social media out there too. And, you know, our kids, it's amazing to me how smart kids are today. Kids today are much smarter about the world than in my generation. There's no question about that. However, kids need adult guidance. And very often adults don't realize just how dangerous the world can be for kids in terms of the influences that are out there. So it's that kind of difficult combination of kids are, a lot of kids being raised right, and a lot of kids whose parents unfortunately don't realize how close to harm their kids actually are.
We have a question here that says, your discussion of what is a high-risk youth begs the question of what constitutes a high-risk treatment program. You already alluded to the current situation in several states whereby the treatment provider is determined by low bidder on state contract, often accompanied by cost-cutting and revolving door staff.
Yeah, so what are the hallmarks of a high-risk program? Sometimes you should just ask the kids. Or ask their families. So let me highlight, there is a program in Arizona, I'm even going to mention names, they're called YDC in Arizona. And I know they've had a policy of involving kids in hiring the staff. They were able to go hundreds and hundreds of days without any physical management whatsoever. Because they developed a culture in which any kind of physical management was viewed as an act of violence perpetrated against the kids. I just saw what time it is. Oh my gosh. What is a high-risk program? A high-risk program involves harsh and confrontational treatment practices and is not willing to or is prickly around having people come in and visit them. I would be asking them what kinds of treatment methods and models they use. And I'd be listening for terms like client-centered, family-driven, good lives model. I mean, I have a conflict of interest with the good lives model because I've published on it and stand to make money on it. But do they use that kind of language at least? Do they talk in terms of strengths-based approaches? And are they willing to show you how they do it? Those would be programs that are going to be lower risk. I'd be interested in your staffing ratio too, although a lot of that tends to be determined. I would not take it as an article of faith that because they're credentialed by, for example, CAR for the Joint Commission or what have you. I would not take that as a sign that they're highly effective clinically. because it's very difficult to judge a clinical program without spending a lot of time assessing exactly that. Many of the credentialing organizations that are out there are actually looking at timeliness of documentation, quality of treatment plans, and other things that, I hate to say it, but are not empirically associated with strong clinical outcomes. They may be important, but it's not the same thing as an effective program. So there, I said it.
We have a question here about adolescents that are in the LGBTQ community who don't have supportive families, and what is done and needed to help them meet their needs and help them prevent being sexually abusive or, you know, abusing someone, being sexually abused or abusing someone else.
Let's be clear, sexual minorities are at risk in treatment, and they're at risk in the same way that many others of ethnic minorities are at risk. Recent study just shown, I came to my attention yesterday from last month, I think, showing that in emergency room placements, Black kids are twice as likely to be physically managed than white kids. In terms of LGBTQ youth, until we have a culture that says that who you are, nobody should feel bad about who they are as a sexual being. Nobody. Period. End of story. There's a lot of sexualities out there. In terms of not having the support of their families, I mean, my message back to families is, do you want to have a kid or not? And there's lots of families out there that, you know, despite their own values and beliefs, seem to come to a great ability to accept their kids for who they are. I don't have a good answer for that question, but my message back to all the adults of the world is please, please, please recognize that being in any kind of minority, sexual, ethnic, etc., is itself an adverse experience. And that until we can take these things seriously, we're not going to reach the kids we're trying to reach. Sorry, I don't have a better answer. If anything keeps me up at night, that's it. And you know what? I'll just say one last thing on that. You know what the best advice I ever got as being a parent was from our Lamaze teacher. The best advice I ever got as a parent was hold your baby. And I think that everything I've learned from reading every study ever done on kids who sexually abused comes back to we should hold our babies and go home and love our families, because that is the biggest protective factor against abuse that there is. Sorry, but that's the closest thing I've got to a really good answer to a great question. And I see we're at time, so.
I have one more question here, and I actually can provide input to this particular answer. It says, Connecticut has automatic transfer provisions from juvenile to adult court on more serious sexual offenses for kids 15 and over, exposing them to adult mandatory minimum sentences, sex offender treatment, and sex offender registration. Are you aware of states that have moved away from these automatic transfers, and what penalties should be imposed for this class of offenders? Actually, in Michigan, I'm from Michigan. In Michigan, for a period of about 20 to 25 years, we automatically waived 17-year-olds with any offense, sexual, non-sexual, to adult court. About a year ago, they changed that. They no longer waive juveniles. 17-year-olds are treated as juveniles. They no longer waive them to adult court, even for sexual offenses. So I am aware of Michigan. Are you aware of any other states that might have done that?
There's some states that are able to hold kids until the age of 21 that I would much rather have them held until 21 than waived up to adult courts, where as far as I know, there's no research showing that helps reoffense rates whatsoever. I don't know what happens up here in ever so liberal Vermont. I don't hear of kids getting waived to adult court at all. I know it's a rarity in the state of Maine, where I lived for a decade. Washington State recently put into a place holding kids. When I say holding, I don't mean inpatient or in juvie. But I believe state of Washington can hold on to kids in the legal system until the age of 25. However, that one's been questionably applied because it meant that some kids who were out in the community were actually pulled back in to detention centers at a lot of detention centers in Washington saying, what do we do with these older adolescents? So that's how I have some knowledge of it.
I guess, oh, go ahead.
Go ahead, Senator.
And because while it's not a direct answer to the question, I do think that if you're listening to this and concerned about it in this respect, you should be very concerned about the state's approaches to the transfer of juveniles writ large. So I alluded to the fact that we're having a conversation in Connecticut right now about juveniles and in respect the car theft thing in Connecticut. And as part of that conversation, there is a conversation about moving backwards on what we've done in the last 10 to 15 years in terms of transfer of juveniles and some other things, right? And so even if a state is good on this, I think it only takes a very small set of circumstances for a state to potentially be looking to walk that backwards. And I think that's important to remember because sometimes particularly in the criminal justice space, we're focused on our part of the conversation and not recognizing how important that the rest of the conversation is to what we're trying to achieve.
Mm-hmm.
And Senator Winfield, can you answer this question? I'm curious, does Connecticut by statute actually waive those juveniles with sexual offenses to adult court? Or is that more of a decision by the court? They have the ability to do it, but it's a decision by the courts. Because sometimes those get mixed up. Or do you have law that actually requires that they're waived up to adult courts?
So you're putting me on the spot to remember what the law actually says. I bet you Jen, who asked that question initially, could actually answer that question. But I will say this, that generally our law, not specifically on sex offenses, if you're over 15 and you commit certain crimes, you can find yourself in the adult court, or if a prosecutor asks for it, you can find yourself in the adult court.
I want to say one more thing. Go ahead, David. I was going to say one more thing in wrapping up here.
Yeah, let's wrap up. And if I could, I'll just say there was a question about culture versus mental health in terms of sex within families. I'm not aware of any data that looks at that. Unfortunately. And then another great question, what can we do to promote secure attachment and prevent future offenses for adolescents that don't have a secure attachment with their families? And I think that's a really good and strong clinical issue. I think you're never too old to have a happy childhood, but that ultimately it goes to show that relationship-based treatments really matter. So I just want to make sure I covered every question. So, thanks, Sharon.
I want to kind of, just to wrap this up, I want to emphasize how you had indicated that one of the factors that we've left out in the past is the whole idea of hope and what hope plays in the future and success of individuals of youth who have sexually offended. And because I do assist in Michigan, juveniles with getting their criminal records set aside. And in Michigan, when that occurs, they automatically come off the registry. And I want to speak to that because I've dedicated a great deal of work to that because it's probably the most rewarding work I've ever done. And I say that because the individuals who come to me to assist them with their set aside and all the legal documents and us preparing that case as to why they should have it set aside, usually come to me with a great deal of depression and a great deal of despair and a great deal of anxiety. And there's nothing like, I have goosebumps even now, I get kind of emotional about it even at times. There's nothing better than when you're in court and you present all this evidence in terms of their behavior, the things that they've done, we present those protective factors and all that in their life. And these individuals, some of them are as near as, 5 years after the offense to 15 years later. And when the judge grants that, I see a totally different person walk out of court that day. I see somebody who, as we walk out of court, saying, oh, you mean now I can go to such and such university? Oh, I am going to go study something. I will be able to get a job. They're these suppressed hopes and dreams that they had were suppressed, exactly that, until such time as something, you know, monumental like this, where that is set aside. And I see a totally different person in terms of, you know, just beginning to walk more lightly, like a yoke has been lifted off their head, and they just go on and do good things.
Nice.
And that's one of the things I share with our legislators here in Michigan, is have been working on set aside law changes. We work on SOAR law changes, and also on the sealing of records, is how important that is for someone to have hope. And I also feel that the ability, when you give them that hope, even when sometimes the hope is not that there's a statute in place. Sometimes the hope is that eventually we'll get to a point where we have a statute that will be useful to them. But when you give them that hope, many of them, that's what keeps them on that straight and narrow. They don't think, you know, hey, I'm screwed. You know, it doesn't matter what I do with my life, you know, because I'm, you know, my future is dismal. But when they have that little bit of hope, that really keeps them going and doing all those pro-social activities and all the things that we really want to see them do.
Yeah, nice. Amen to that.
Mm-hmm.
So, all right. Well, thank you for having me. And it's great to see so many of you again, and to meet new people that I haven't met. So with that, I think we're done.
Thank you.